So today we're going to talk about supraventricular tachycardias. My name is Usha Tedrow, and I'm the director of the Clinical Cardiac Electrophysiology Program at Brigham and Women's Hospital. Here are my disclosures. So supraventricular tachycardia is any arrhythmia that requires only atrial or AV nodal tissue for its initiation and perpetuation. The differential diagnosis includes regular tachycardias and irregular tachycardias. The regular tachycardias are listed on the slide and include AV NRT and AV RT, which are the most common and we're going to focus on this talk. The irregular tachycardias, which are going to be covered elsewhere, include atrial fibrillation and multifocal atrial tachycardia. So shown here are two ECGs. One shows sinus rhythm, where you can see upright P waves in lead 2 and biphasic P waves in V1. You see then a narrow complex tachycardia with no clear visible P waves. What you might notice is at the terminal portion of V1, in tachycardia, you see a small R prime compared to V1 in sinus rhythm. This is blown up here on the slide to show you more clearly how there's a little bump there at the terminal portion of the QRS that's absent in sinus rhythm. That's representative of a retrograde P wave, and it's indicative of a short RP tachycardia. The most common short RP tachycardia is AV node reentrant tachycardia. This is the most common paroxysmal supraventricular tachycardia, and it accounts for about 50 to 60% of patients with a regular narrow complex tachyarrhythmia. We most often see it in patients with structurally normal hearts, but it can be seen in patients with structural heart disease as well. There is an epidemiological female to male predominance, and the etiology is dual AV nodal physiology. The ECG shows, as we just took a look at just a moment ago, a pseudo R prime in V1, or you can sometimes see an S wave in 2, 3, and AVF. I can actually back up and show you that as well. If you look at the terminal portion of the QRS here in lead 3, you can see in tachycardia there's a tiny little S wave that you also see in tachycardia. Typically, the RP interval is much less than the PR intervals, and sometimes no P waves are seen at all. It typically terminates with adenosine because adenosine slows conduction in the AV node, and it's an arrhythmia that's highly amenable to catheter ablation. So what's the pathophysiology of AV-NRT? It uses dual AV nodal pathways, and this is a little cartoon showing you atrial tissue at the top, the AV node in the middle, and the ventricles down below. So in sinus rhythm, we typically have an impulse that's propagating through the atrium and going through a fast pathway with blocking in a slower conducting AV nodal pathway that propagates down to the ventricles. In the typical situation, when there's a premature atrial contraction, it often blocks in the fast pathway and conducts slowly down the slow pathway and propagates down to the ventricles. If the fast pathway is recovered by the time the slow pathway conducts down, you can get a circuit that forms, and that creates typical AV node reentrant tachycardia. So how do we ablate AV node reentrant tachycardia in the EP lab? So here's an example of a right anterior oblique projection of some catheters in the heart. And what you can see is a high right atrial catheter up in the high right atrium. You can see a His bundle catheter that's sitting right at the tricuspid annulus. And then there's a right ventricular catheter that traverses the tricuspid annulus and goes right down to the right ventricular apex. In addition, there's a multipolar catheter that's sort of diving away from us into the coronary sinus, and this wraps around the mitral valve annulus and gives us some idea of activation in the lateral portions of the heart. So here's an example of what the signals from those catheters look like in a typical EP setup. So just to get you used to what we're looking at here, we're going at a pretty fast paper speed. So the QRS complexes here are actually narrow, even though they appear wider than you would see on a typical ECG. The first 5 tracings up here are leads from a surface ECG. Then you see tracings from the high right atrial catheter. You see tracings from the coronary sinus catheter, and then you see tracings from the His bundle catheter, and then from the right ventricular apex. Here we're actually pacing from the high right atrial catheter, and you can tell that we're pacing because there's a stimulus channel down here, and you see a big artifact on the stimulus channel. And what we've done is we've done a drive train of 8 paced beats with an early extra stimulus that's added here. And we see here when we pace the atrium, the signals propagate through the atrium, and then we see the His bundle activate, and then we see the ventricles activate here. With the extra beat, you notice that the atrial beat comes and looks about the same as before, but it's a little bit longer time delay through the AV node to reach the His bundle here. If we bring that extra stimulus in just a little bit earlier, we find that that AH time, let me show it to you again, here's the AH time that here was 149 milliseconds. It jumps out all of a sudden to 307 milliseconds. This is a discontinuity in the delay in the AV node, which indicates a jump from the fast pathway to the slow pathway. The other thing that you notice, if you compare this tracing with this tracing, is that here tachycardia starts all of a sudden. And here there are a whole bunch of atrial beats that are the result of retrograde conduction through the fast pathway. So this is typical slow, fast AV-NRT. Something that's sometimes done in the EP lab is the A1A2s, which are the A1A2s from the extra stimulus train, are plotted against the A2H2s from the stimulus train, and you can see here evidence of a pre-ablation discontinuity that shows dual AV nodal pathways. And after you ablate the slow pathway, which is how we treat AV-NRT, you see a more smooth A1H2 curve. Here's another tachycardia that we're going to talk about today. This is AVRT. So here we see a narrow complex tachycardia again, but if you look in the inferior leads, which I have blown up for you here, you see that though it's a short RP tachycardia, the P wave comes a bit further away from the QRS complex than it does during AV-NRT. So this is a short RP tachycardia. You see retrograde P waves. There's a 1-to-1 relationship between the R waves and the P waves. So this is an example of AVRT. So AV reentrant tachycardia is the second most common form of SVT. It has a 0.1 to 0.3% incidence. The age of onset is often younger than in AV-NRT. It occurs often in structurally normal hearts, or it can be seen in some forms of congenital heart disease, most commonly Ebstein's anomaly, where patients can have multiple accessory pathways. There's a male to female predominance of 2-to-1, and it requires the presence of an accessory pathway. An accessory pathway is a bridge of myocardium that connects the atrium and the ventricle, and they can be antegrade conducting only, which is very rare and is called a Maheim fiber. They can be retrograde only, which is called concealed. These are the most common, actually. And then they can be bidirectional, where they produce a delta wave on the surface ECG, which we call Wolff-Parkinson-White syndrome. In sinus rhythm, the ECG can be normal if there's a concealed accessory pathway, or you can see pre-excitation or a delta wave in Wolff-Parkinson-White. When you have narrow complex tachycardia, it's called orthodromic AVRT because the conduction is going down the AV node and retrograde up the accessory pathway. And it's usually a short RP tachycardia, but the RP is not as short as what we usually see in common AV-NRT. Here's an example of the orthodromic AVRT circuit. You see the AV node up here, 2 atria, 2 ventricles, and here's the His-Purkinje system. And you see this little circuit going on down the AV node through the His-Purkinje system and up the accessory pathway, and that propagates the circuit. Here's an example of a patient with pre-excitation, Wolff-Parkinson-White syndrome, or a delta wave. All of those things refer to the same thing. Here, one of the things I find the most difficult about this ECG is to find the P waves. So look for areas on the ECG where you can find the P waves most distinctly, and then take a look for the QRS complex. And what you can see here is that the QRS complex starts right as soon as the P wave is over, and there's this slurring in the onset of the QRS complex. and that's indicative of pre-excitation. The reason that you see that is because the electrical activity is a race between the atrium going through the AV node, which doesn't produce any electrical deflections, and going through the accessory pathway, which produces the slurred onset to the QRS. So Wolff-Parkinson-White syndrome was first described in 1930, 11 patients with a paroxysmal tachycardia and a short PR interval on surface ECG. And in 1943, it was discovered that this was the result of pre-excitation from bundles of Kent that were anomalous extranodal tissue, that were these connections between the atrium and the ventricle that bypass the normal AV conduction system. There are two important definitions when you're thinking about Wolff-Parkinson-White. There's the pattern, pre-excitation pattern, so a surface ECG with a short PR, a widened QRS, and a delta wave that is related to a bypass tract, but may or may not be associated with any arrhythmia. And then there's Wolff-Parkinson-White syndrome, that's pre-excitation that is associated with tachyarrhythmias that utilize the accessory pathway. An accessory pathway is an incomplete segmentation of the embryologic cardiac tube and formation of the fibrotic AV ring. Most of the cases are sporadic, but a very small percentage have a familial pattern of inheritance. The Wolff-Parkinson-White pattern is 2 to 3 out of 1,000 in the general population. The Wolff-Parkinson-White syndrome is 1 to 2% per year of patients with pre-excitation, and 0.5% in first-degree relatives. 13% have multiple accessory pathways, and 20% tend to lose pre-excitation over 10 years follow-up. In particular, if you pick up accessory pathways and pre-excitation in adulthood, they're very likely to spontaneously lose pre-excitation over time as the pathway involutes. So where are the common places that we find these accessory pathways? The location can be along the mitral and tricuspid annulus. By far the majority are found in the left free wall, so the lateral mitral annulus. The next most common is a post-receptal pattern. 13 to 21% are in the right free wall, and 2% are anteroseptal, and it's important to recognize those because the pathway can be right on top of the His-Purkinje system. So here's a common pre-excitation pattern, left lateral pre-excitation. Now you might say, oh, I'm looking at the QRSs here in 2, 3, and AVF, and I don't see a lot of slurring. I see a little bit of slurring, but when you look at V2, you can pretty clearly see that there's a lot of slurring in V2, a lot of slurring in V1. So the delta wave is definitely there, and it's fairly typical to have not so prominent pre-excitation in left lateral pathways because the pathway is so far from the natural conduction system. One of the key clues on the surface ECG that you're dealing with a left lateral pathway is if you look in AVL and the delta wave is negative, that is a left lateral pathway until proven otherwise. Another common pre-excitation pattern is posteroceptal, and this pattern is important because it creates a pseudo-infarct pattern on the ECG. You have negative delta waves in 3 and AVF that can look like Q waves. So this is a posterior pattern, and for it to be posteroceptal, typically the delta wave changes polarity between V1 and V2, as we see here, and that puts it on the septum. Arrhythmias that are dependent on the accessory pathway can occur during Wolff-Parkinson-White syndrome and include orthodromic AVRT, as we already talked about, and then they can have antidromic AVRT. That would produce a wide QRS where you go down the accessory pathway and up the AV node. And they can also have arrhythmias that are not dependent on the accessory pathway, a so-called bystander accessory pathway. So they can have atrial tachycardias, AVNRT, junctional rhythms with bystander accessory pathway. You can also have atrial fibrillation that occurs in 15 to 30% of patients with Wolff-Parkinson-White, and this is a very dangerous arrhythmia, as we'll look at in just a moment. And then we see atrial flutter in about 5%. It has been estimated that 1/3 of patients with Wolff-Parkinson-White also have episodes of atrial fibrillation, as we just mentioned. Spontaneous atrial fibrillation is more common in those with accessory pathways that can conduct very rapidly, so that means they have short refractory periods. Accessory pathways that conduct antegrade, and it's uncommon in patients that have a concealed accessory pathway. So if a patient has a normal surface ECG but has orthodromic AVRT, they're at very low risk. The pre-excitation, we think, predisposes to atrial fibrillation. The mechanism of that is unknown. It's unknown whether there is potentially micro reentry that occurs in the accessory pathway that predisposes to atrial fibrillation. Oftentimes, you'll see patients be in AVRT that then degenerates into atrial fibrillation. And the rapid atrial rate may create a substrate for atrial fibrillation due to recurrent episodes of SVT that predispose to atrial fibrillation as well. Here's an example of atrial fibrillation in Wolff-Parkinson-White syndrome, and it's a very dangerous looking arrhythmia. You see how it looks very irregular, but even though the rhythm is irregularly irregular, the majority of the QRS complexes actually look of the same morphology. What you can see here is that there are some RR intervals that are slightly longer, some are as short as 200 milliseconds. These are all occurring through the bypass tract. So if someone asked me where this bypass tract is, there are Q waves in 2, 3, and AVF, so that would put it as a posterior accessory pathway. You do see occasionally captured beats that are going through the normal conduction system, but that's not the rule, that's the exception. So how do patients get sudden death in Wolff-Parkinson-White? Rapid conduction to the ventricles during atrial fibrillation can degenerate to ventricular fibrillation. The things that predispose to that happening is short antegrade conducting refractory periods and multiple accessory pathways. The incidence of ventricular fibrillation in symptomatic Wolff-Parkinson-White patients ranges from 0.15 to 0.39% annually. Sudden death can be a rare first presentation of Wolff-Parkinson-White, particularly in children, and in up to 50% of resuscitated arrests in Wolff-Parkinson-White, it is the first manifestation of their Wolff-Parkinson-White syndrome. So how can you do risk stratification in patients with pre-excitation who haven't had any tachyarrhythmia episodes? One option is to do a Holter or serial ECGs and look for intermittent loss of pre-excitation, which can indicate that the pathway is not very robust. A stress test that shows sudden loss of pre-excitation at a low critical heart rate can also suggest that the pathway is not so risky. The only problem is that if it's a left lateral pathway, sometimes these non-invasive methods are not so specific. So we want to do an invasive EP study, particularly for younger patients. We look for an antegrade effective refractory period or shortest pre-excited RR interval of less than 250 milliseconds. If you remember from that example I showed you, the shortest pre-excited RR interval was about 200 milliseconds in AF, so you know that that was a risky pathway. The sensitivity of this measure is good, but the specificity is only fair. Other risk factors are demonstrating, again, multiple accessory pathways, and then inducibility of SVT on EP study is also a risk factor. So if you see patients with a Wolff-Parkinson-White pattern on ECG, symptomatic patients should be referred for radiofrequency ablation. SVT, AF, syncope, palpitations, all of those count as symptomatic for the patient. We may place patients on class 1C antiarrhythmics such as flecainide or propafenone while they're awaiting ablation. However, should everyone with a WPW pattern on ECG receive an EP study and ablation? Many accessory pathways may not be so risky for the patient, and doing an EP study might be risky in and of itself. So we definitely would want to do exercise testing for right-sided pathways, but err on the side of EP study for left-sided pathways. So let's talk about a case. Here's a 28-year-old woman with palpitations. Her episodes last 15 to 20 minutes, worsening in frequency and severity with worsening lightheadedness. They're often terminated with a Valsalva maneuver. But one long recent episode required emergency department visit, and the tachycardia had to be terminated prior to arrival. She had a structurally normal heart by echocardiography, and event monitoring was ordered. So here's her event monitor. What's the diagnosis? Is it 1, atrial tachycardia, 2, AV node reentrant tachycardia, 3, orthodromic AV reentry, 4, antidromic AV reentry? So the answer is AV node reentrant tachycardia, and I'll show you why. Here we have a simultaneous ECG from a Holter monitor, and we see there's a P wave and a QRS, a P wave and a QRS, a P wave and a QRS. But here we see 2 premature atrial contractions. The P waves look slightly different, right? There's one here and there's one here. And you see on the second one, it conducts to the ventricle with a very long PR interval compared to the prior. And what you also see is right after that, you see a little retrograde P wave hugging the end of the QRS complex, which we didn't see before, and then we're off to the races in tachycardia. So this is most consistent with initiation of an AV node dependent arrhythmia that is reentrant in nature, and that would be AV node reentrant tachycardia. Here's another case, this 17-year-old man with a history of atypical chest pain, pre-syncope and palpitations, who has a structurally normal heart. He underwent ambulatory monitoring, which showed a sustained wide complex tachycardia. He was referred for an EP study. So here's a 12-lead ECG of his wide complex tachycardia. Now again, you have to get used to looking at the fast paper speed. This is a left bundle branch block type pattern. It is a wide QRS, but maybe not as wide as you'd think with the fast paper speed. So here's V1, it's down going in V1, and it's positive in V6. So it looks like a typical left bundle type pattern. So what is the differential diagnosis of a 1-to-1 wide complex tachycardia? There's ventricular tachycardia, there's supraventricular tachycardia with aberrancy, so conducting down a left bundle branch block. There's pre-excited tachycardia. There could be antidromic AV reentry, either by a standard atrioventricular accessory pathway or another type of accessory pathway. Or it could be a bystander pathway producing a wide QRS in the setting of some other SVT. So here is his wide complex tachycardia with his intracardiac tracings. So you see here again is V1 with that down-going wide complex. You can see lead 2, lead 1 up here, and lead 3. Here's again a coronary sinus tracing, here, here, here. And here's the His bundle tracing. And one of the things you notice is that there's a His bundle deflection in front of each QRS. That's something that we see when there's aberrant conduction, because if something conducts from atrium to ventricle with a left bundle branch block configuration, you'll see a His deflection in front of each QRS complex. We also observed something very interesting during this study, is we saw him go from a narrow complex tachycardia spontaneously to a wide complex tachycardia. And we noticed that the rate of the tachycardia changed, that it actually got a little bit slower when the left bundle branch block took over. Is this tachycardia most likely due to a left-sided accessory pathway, a right-sided accessory pathway, AV nodal reentry, or atrial tachycardia? So the answer is that this is due to a left-sided accessory pathway. And this is because we observed that when we see block, which means left bundle branch block, ipsilateral to the pathway, ipsilateral to a left-sided accessory pathway, we see an increase in the tachycardia cycle length, which means a decrease in the rate of the tachycardia. And here's just a little cartoon to show you how that works. So here's our little cartoon of the AVRT circuit again, going through the AV node and up the accessory pathway. And when we get ipsilateral left bundle branch block, the path length for the circuit becomes longer because you have to go down the right bundle and have transeptal conduction and then retrograde conduction up the accessory pathway, and that produces a slower rate. So this observation that ipsilateral bundle branch block slows the tachycardia cycle is diagnostic of AVRT. And here's another case, a 17-year-old athletic man with a history of palpitations and syncope. He presents to the ED with the following ECG. Is the pathway location at the left ventricular apex, the right ventricular free wall, the lateral mitral annulus, or the anteroseptum? The answer is the lateral mitral annulus. And that's because if we look here at lead AVL, we see that the deflections are negative. And we said that if the deflections are negative, then it's likely a left lateral pathway causing this tachycardia. So the pathway is a left lateral pathway, which is located at the lateral mitral annulus.